Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It's a pleasure having you. I'm here introducing our webinar for today, inshallah, which is the Excellence in Healthcare Career Pathway. I want to welcome all the people who joined us or who are still trying to join us. As you can see, today we have in collaboration the Arab Association of Pharmacy Progress Group, which is a society that is located in Cairo. Dr. Samer Rafai will be presenting it. He's the president of this group. Also, we'll have our pioneers in pharmacy, and we will see their topics and their unique way of introducing their experience in pharmacy. And I'm actually honored to start by giving a glance to this webinar. As you can see, this webinar is done by the Saudi Clinical Cardiopharmacy Group, which is under the umbrella of the Saudi Heart Association. I do really want to thank the Saudi Heart Association for this great support and, of course, collaboration with different societies and groups around the kingdom and outside. Also, I want to thank Merck for sponsoring this webinar. It's a very good initiative. And also, it took us to another wave, which is the metabolic syndrome, which we are trying to focus on by different topics today. To start with today, I want just to introduce this group for our audience who are newly joining this webinar, people who are coming from different regions and outside Saudi Arabia. The Saudi Cardio Clinical Pharmacy Group, it's actually a group that is initiated 4 years back. And just to give time for the people who are still joining us, أنا بصراحة كنت أبغى أبدأ بكل عام وأنتم بخير جميعاً، بس مستني الكل يكون معنا. I will say it again at the end of this webinar. الحج على الأبواب، الأيام فضيلة الآن، أيام العشر ذي الحجة. أتمنى من الله سبحانه وتعالى يحقق آمال الجميع. الحج للأسف هذه السنة كان شوية محدود بحكم طبعاً الوباء اللي بنمر فيه كلنا الآن، لكن بإذن الله ستفرج قريباً. وأهلاً بكل الحجاج اللي تم الموافقة لهم بإن شاء الله أداء هذه الفريضة، وكل عام والجميع بألف خير يا رب. The Saudi Cardio Clinical Pharmacy, of course, was initiated, as I told you, a few years back. We have a purpose and we have objectives for that. The most important thing is that we want to give an organization for the clinical pharmacists who are experts in their field, telling us about what is the problems that we have in our treatment, and also what is the proper guidelines, and of course to have a dedicated group who's supposed to be acting for the patient care. We have a lot of instructions and legal authorities and so on, but the most important thing about this group is that they are working actually voluntary. What I mean by voluntary, we have no economic benefits of having this group. The mission is to improve the quality of life and the longevity, of course. المشكلة طبعا في بعض المرضى وخاصة المرضى اللي هم في الأمراض المزمنة، مشكلتهم الأساسية إنها للأسف بطول العمر طبعا بقدرة الله سبحانه وتعالى، ولكن نوعية الحياة اللي بيكونوا عايشينها حياة شوية متعبة. فهدف هذا المجموعة إنها توجد بعض إن شاء الله بإذن الله الجايد لاينز، وطبعا أهم شيء إنها تقدر إنها to improve the quality of this patient's life، كيف يقدر يعيش بحياة أطول شوية إن شاء الله ولكن بنوعية أفضل. الحاجة الثانية المهمة جدا achievements that we are looking for is مش بس نشتغل على إنه we are only one group. هدف رئيسي منها إنه يكون في standard of ethics that we all should follow. كنا clinical pharmacists or physicians or nursing, we are working all together for the patient, of course, outcome. A lot of activities طبعا شاركنا فيها وحنتكلم عنها الآن بتفاصيل أكثر، وفينا نطلع الآن طبعا الأشياء أهم وأهم نسويها، وكل ما إن شاء الله بيكبر الجروب كل ما بتزيد التعاونات كل ما الإنجازات متوقعة تكون أفضل. زي ما قلت لكم, it's a cardiometabolic syndrome. We are going now to cover a lot of healthcare practitioners' specialties because they need this. Annually we have to submit a report. الريبورت هذا بيحوي على first of all guidelines سوتها للجروب. الحاجة الثانية فيها education للpublic for prevention، لأن جزء كبير من العلاج هي الوقاية. والجزء الأهم فيما بعد اللي هي guidelines اللي هي موحدة في كل المملكة، وفيما بعد طبعا تكون فيها international. إن شاء الله standard. We did lots of activities. شاركنا في كثير من المؤتمرات المحلية والعالمية، لكن برضو في الهيلث كير professionals in general. ما كنا نحدد فقط الفارماسيست. No, our indicator was all the health care professionals. برضو حاجة مهمة جدا الببليك، وهذه كانت من الأشياء اللي كنا نتميز فيها كجروب، إنه كانت بتوجه للأدوية، الأكل بيتفاعل مع الأدوية، والوقاية للمرضى المزمنين. عملنا our own courses اللي كانت لها approval عن طريق الهيئة السعودية للتخصصات الطبية، كانت موجهة طبعا للskills والsoft skills of practitioners. سوينا episode 1, episode 2, and we are still inshallah in the success form because we believe that we have some lack of information, so we need to improve this. برضو كان لنا collaboration في دول الخليج، كان لنا collaboration برضو في دول العربية والميدل إيست. Now we are collaborating today with Egypt for our first webinar, but we had also collaboration with them in their international conferences before. Now we are planning to go even beyond, and we did already do ISTH. We did a collaboration. We have a chapter with them now by the Saudi name. The WHO برضو في European also we are الحمد لله رب العالمين سوينا اتفاقية معاهم. خلاص we are going through إن شاء الله specialized courses for pharmacists and healthcare professionals. Canada, USA, and so on. Again, I always say the sky is our limit. We know that we still have space to work together. Automation is very important now, and we believe in automation in our career. That's why, inshallah, our next step is to go to biosimilars and automations and more and more. This is just to say hello, welcome to our webinar. And now, of course, it's a pleasure, inshallah, to introduce our first speaker for today, Dr. Mohammed Al-Shinawi. Dr. Mohammed, I will just leave the, yes, I need you to share your slides. Dr. Mohammed Al-Shinawi, he is the General Director, General Administration of Pharmaceutical Care in the MOH. He is, mashallah, tabarakallah, a very creative pharmacist. He gives a lot of his experience to the MOH. But the Saudi Pharmacy Society, he's introducing this society in different aspects, different forms. But today he's going to talk to us about hypothyroidism and the pharmaceutical care in the MOH. تفضل دكتور محمد.
شكرا جزيلا يا دكتورة، ومساء الخير جميعا وأهلا وسهلا فيكم. It's my pleasure today to be with you all, and it's my pleasure to be with the Saudi Cardio Clinical Pharmacy initiatives, as well as with any initiative that it will introduce us and it will introduce our work to all of our colleagues in the Arab world. I'm happy to see this cooperation, and I am sure that in the future it will enhance more and more. And we are looking for more cooperation between us and collaboration that it will result, inshallah, in enhancement in our pharmaceutical career. Excuse me, my voice is, it's not corona, but it is, I need to drink some lemon maybe. Thank you, everybody. I will start first by introducing the protocol for management of hypothyroidism, a consensus of GCC countries, Gulf countries. This roadmap is guidance for healthcare professionals addressing the management of hypothyroidism. As an introduction, the rationale for the diagnosis and management of hypothyroidism roadmap starts with the hypothyroidism. زي ما كلنا نعرف, it's caused by inadequate production of thyroid hormones or an inadequate replacement following the thyroidectomy, which leads to low circulating and tissue levels of thyroid hormones. As hypothyroidism is commonly and frequently underdiagnosed, millions of people worldwide are unaware that they have the disease and remain untreated. In GCC countries, as the study said, the prevalence of hypothyroidism ranges from 7% to 41%, which is a very high percent. And rates of subclinical thyroidism are typically more than twice that reported in the US. A high prevalence rate of hypothyroidism is typical among pregnant women in the GCC countries. Untreated hypothyroidism can contribute to hypertension, dyslipidemia, infertility, cognitive impairment, and neuromuscular dysfunctions. There are currently inconsistency of and some controversies in the management of hypothyroidism in GCC countries. The roadmap has been developed by leading the Gulf countries, endocrinologists, and policy advisors to provide recommendations on the diagnosis and management of hypothyroidism in Gulf countries. We will come to patient screening. First of all, it is recommended that the following patients be screened for hypothyroidism by measurements of plasma thyroid stimulating hormone or TSH level. And we will have, after the recommendations, we will have 3 categories. We will go one by one. For the male, if they have 4 or more of the following symptoms, we will start the screening: fatigue, sleepiness, cold intolerance, goiter, dry skin, weight gain, or constipation. 4 of them, combined 4 of them, will put the individual for screening. Patient screening for female, unexplained student growth, dementia, psychiatric disease, genetic syndromes, neck radiation, use of drugs that affect thyroid function, dermatologic disease, hyperlipidemia, cardiovascular disease, autoimmune disease, hypercholesterolemia, infertility, or menstrual irregularities. So any patient will have, any female patient will have those, any kind of history of those is eligible to start the screening immediately. Pregnant ladies with a history of family history of thyroid disease, which is very common, by the way, and thyroid disease during pregnancy, type 1 diabetes or autoimmune disease, complicated pregnancy. إذا حصل عندها قبل كده miscarriage أو إسقاط للحمل, recurrent miscarriage, menstrual irregularities, or presence of antithyroid peroxidase antibodies. طيب. وصلنا إلى مرحلة diagnosis of hypothyroidism. We find that after doing the lab test for the TSH, thyroid stimulating hormone, that the TSH is elevated. Then we have to go for a second test that it's called for the free thyroxine, FT4, or the T4 levels, subclinical or overt thyroidism. So we will have 2 directions. The first direction is if the TSH is elevated more than 10 mu per liter and FT4 is low, then it is diagnosed as having overt hypothyroidism and should be treated immediately. Second direction, if the TSH is elevated with abnormal levels of the FT4. This is diagnosed of having subclinical hypothyroidism, and the management algorithm in the next slides will recommend to be followed. This algorithm shows the patients with overt and subclinical hypothyroidism should be managed. Management of hypothyroidism. So elevated TSH, immediately we will go to, if it is more than 10 mu per liter, overt hypothyroidism, and we will go to treat. If it is a subclinical hypothyroidism, then we have to repeat the TSH in a duration of from 1 to 3 months. Then if the TSH level is between 5 and 10 mU per liter for the second time, we have to go for the thyroid peroxidase antibodies, and the thyroid peroxidase antibodies is negative, then no compelling indication, and then observe. We have to observe the patients. If the TSH is more than 10 mU per liter for the second time, then the thyroid peroxidase antibodies is positive, then complete indication, then we have to treat. Then we will come to the common treatment and treatment of the hypothyroidism, levothyroxine. Treatment dosing schedule. The following table should be start. Levothyroxine, as we all know, this is the common pharmacist counseling to any patient, that you have to take it on empty stomach قبل الإفطار بساعة, at least 1 hour before the meal, usually before the breakfast in the morning. And we should keep in our consideration that a lot of medications should be administered at least 4 hours either side from levothyroxine, either before or after. And many of those items are, in fact, highly taken by patients, like the calcium supplements. Calcium supplements is very common taken by patients. Proton pump inhibitors, omeprazole, Nexium, all of the proton pump inhibitors should be at least 4 hours before or after. Bile acid sequentrants and biophosphonates, ferrous sulfate, حبوب الحديد, aluminum containing antacids, sucralfate, and anticonvulsants. Those to minimize the possible interactions that it may result in decreasing or increasing the levothyroxine level in the blood. Management of adults, newly diagnosed, healthy, young to middle-aged patients. Of course, we are targeting here less than 65 years of old, 65 years of age, who have no comorbidities or cardiovascular risk factors. Full levothyroxine starting from 1.6 microgram per kg per body weight. For the elderly, as we mentioned in the previous slide, more than 65 years of old, the TSH level may normally be slightly over the normal range. بمعنى إنه والله لو عندي الوالدة الله يعطيها الصحة والعافية عندها levels of TSH مرتفع عن ال upper level, ساعتها it should not be automatically treated. It is recommended to look for the following before initiating any treatment. إذا ما في أي علامات, no signs or symptoms, a period of observation and reassessment is recommended. For example, repetition of TSH level as a lab test. And symptoms or signs suggestive of hypothyroidism associated with cardiovascular disease or multiple risk factors for cardiovascular disease, and or positive anti-TPO thyroid peroxidase antibodies. Then the levothyroxine therapy should be considered at that time at starting dose of 25 to 50 microgram per day, raised by 25 microgram every 1 to 2 weeks until the full dose is reached to that patient. So you will start gradually titrating the dose up. Management of pregnant women. Levothyroxine is titrated dose to keep the TSH within the trimester specific range. So we have to tailor the levothyroxine dose to reach our specific TSH level, which is in the first trimester is from 0.1 to 2.5 MU per liter. Second trimester is 0.2 to 3 MU per liter. And the third trimester from 0.3 to 3 MU per liter. The serum thyrotropin levels assessed every 4 weeks during the first half of pregnancy to allow dose adjustment. Serum thyrotropin reassessed during the second half of pregnancy every 4 to 6 weeks to allow dose adjustment. In the pediatric or neonates, so the neonates up to 6 months, years of old, the starting dose of the levothyroxine is from 10 to 15 microgram per kg per day. Above 6 months to 1 year old, it will be from 8 to 10 microgram per kg per day. From 1 year to 2 years old, it will be from 6 to 8 microgram per kg per day. And the older than 2 years of old, from 5 to 6 microgram per kg per day. And usually the tablet can be dissolved in a small amount of water or formula or milk. Then you have to take the adjusted dose according to the dose of the patients. And I believe this is a good time to mention that to our colleagues in Merck that having a formula, syrup formula or suspension formula for those young patients is very necessary to be available, and we highly recommend to have it. So as finally for my brief and summarized and quick presentation to you today, I hope that I was not a heavy talker to you. First of all, hypothyroidism is common, but majority of time it is underdiagnosed disease. All patients at risk or possible risk of hypothyroidism should undergo measurement of plasma TSH level. The decision to initiate the treatment depends on multiple factors, including the baseline of the TSH and the free thyroid, the free T4 levels, symptoms and signs, the thyroid polyoxidase positivity, antibodies, comorbidities, patient age, fertility, thyroid size, and other factors. Pregnant women, elderly patients, and children have different clinical consideration and or TSH cutoff levels, which require different thyroid replacement approaches and doses. Again, those recommendations should help to guide clinicians in the diagnosis and management of those patients with hypothyroidism in Gulf countries. Again, شكرا جزيلا وتمنياتي بالتوفيق للجميع وشكرا دكتورة. I will leave now talk to you. Thank you.
Thank you very much, Dr. Mohammed, for this very nice capsulated, summarized presentation. We have a few questions that we'll leave it till the end of this webinar, inshallah. Also for the CME hours, I want to أبغى أطمن الكل بإذن الله في عليها ساعتين CME hours. الشهادات إن شاء الله هتصدر خلال 10 أيام من حضوركم للويبينار. اللي عنده مشكلة في الشهادة أو عنده مشكلة في CME hours, please راجعوا السعودي Heart Association. اكتبوا لهم لأن هم they don't know that you have a problem. لكن الجميع إن شاء الله يحصلوا على ساعتين CME hours within 10 days, والشهادات بإذن الله حتطلع خلال هذه الفترة. شكرا دكتور محمد. الآن معنا الدكتور سامر الرفاعي. دكتور سامر الرفاعي he is the president of the Arab Association of Pharmacy Progress. مقره في القاهرة، مشكورا من إيجيبت الآن وهو معنا. هيتكلم بإذن الله عن أول حاجة من هم this association ويتكلم عن الميشن والفيجن حقتهم. الجزئية الثانية بإذن الله هيتكلم فيها عن experience of Egypt in pharmacovigilance. دكتور سامر مشكورا، إن شاء الله حيبدأ الآن. تفضل دكتور سامر.
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم، برحب بكل الزملاء الصيادلة وزملاء اذا كان معانا كمان اطباء او اعضاء تمريض، اهلا وسهلا بيكم، كل عام وانتم بخير. Thank you, Dr. Fah, for moderating this professional webinar. Today we are launching the first of a kind cooperation between the Saudi Cardio Clinical Pharmacy through the Saudi Heart Association and our organization, the Arab Association of Pharmacy Progress. Now I am going to tell you the story behind constituting the Arab Association of Pharmacy Progress. الاسوسيشن بتاعتنا او الجمعيه was established in order to raise the scientific and the professional level of Arab pharmacists. The association was announced through the Ministry of Social Solidarity اللي هي وزاره التضامن الاجتماعي. وزاره التضامن الاجتماعي هي اللي بتدي الترخيص عندنا في مصر للاسوسيشنز اللي هي NGOs, non-governmental organizations and non-profit organizations. I would like to say that we cooperate with national and international scientific entities, leading pharmaceutical corporations and medical partners to create and disseminate knowledge and best practices. احنا اهم objective عندنا ان احنا to disseminate, create and disseminate knowledge. وانا دايما اطلق على الجمعيه بتاعتنا لفظ catalyst because we don't own any material or resources. We rely upon each specialized entity and organization, and we work as a catalyst. So we catalyze creating and disseminating knowledge and best practices. Next, please. Next. Okay. To tell you about our mission and vision, احنا ركزنا قوي ان هي تكون very short and focused علشان كل واحد فينا يقدر to retrieve الميشن والفيجن بمنتهى السهوله. Our mission is to energize the pharmacist role in medical community. Very simple. And our vision is to make a quantum leap in pharmacy career by end of 2030. احنا الحقيقه بدانا الكلام ده من سنه 2016 لما اسسنا الجمعيه. بقى لنا 4 سنين شغالين حتى الان، عملنا خطوات لا باس بها، لكن الكوانتم ليب او النقله النوعيه ان شاء الله باذن الله تتحقق على 2030 if not before. Next. احنا we have 4 major goals. The first of all is to enhance the competencies and the capabilities of Arab pharmacists and to reduce the gap between pharmacy education and the practice, to foster collaboration among different pharmaceutical sectors, and to help in rebuilding a better pharmacy career. Next. احنا طبعا علشان نحقق الميشن والفيجن دي في عندنا مين توبكس نحب ان احنا دايما نبقى فوكسنج عليها. احنا الحقيقه جمعناهم في 10 مين توبكس. قدرنا ان احنا نحقق بعض الاكتيفيتيز اللي احنا ذكرناها في ال 10 توبكس دول وبعضها بوست بون. الحقيقه احنا الفوكس بتاعنا كان اول ما ابتدينا على الهوسبيتال فارماسي والكلينيكال فارماسي، وفوكسنج قوي على الرول اوف فارماسيست ان بيشنتس ان هيلث كير. وده خلانا نبعد شويه عن الرول بتاعت الفارماسي في الكوميونتي فارماسي. احنا الحقيقه دي اللي هي نمبر 10 اللي هي استراتيجيز انهانسنج ذا رول اوف كوميونتي فارماسيست بوست بون شويه لغايه لما نحقق الاوبجكتيفز بتاعتنا في الكلينيكال والهوسبيتال فارماسي. فاحنا حاليا مركزين على نمبر 1، مركزين ايضا على الامباكت اوف تكنولوجي، الفوسترنج ديلي فارماسي براكتس والكلينيكال فارماسي ورك شوب اللي هي نمبر 9 بلس الانوفيتيف ابروتشز ان فارماسيوتيكال ساينس. احنا تقريبا بنغطي 80% يعني 8 بوينتس من ال 10 بوينتس دول، وان شاء الله على افتر 2 years هنكون مغطيين 9 بوينتس، وعلى 2025 هنابروف الكوميونتي فارماسي باذن الله. نيكست بليز. طيب ليه يو بلاش يشود يعني ليه نفضل ان انتوا تجوين العرب اسوسيشن اوف فارماسي بروجرس ويبقى في كوبريشن ما بيننا وما بين بعض؟ لان احنا بنقدم مجموعه من الاكتيفيتيز المفروض ان احنا مش هيكتب ليها النجاح او هتبقى successful unless ان كان في cooperation ما بينهم وبين بعض. فانا هديكم بعض الاكزامبلز من الاكتيفيتيز اللي احنا بنعملها. احنا بنعمل اون كوارترلي بيسس الفارما نيوز ماجازين. دي بتبقى عباره عن مجموعه من الارتكلز بيعملها مجموعه من الصيادله البروفيشنالز وبعض الفيزيشنز ايضا عن ريسنت ابديتس في الفارما ساينس. عاملين بروجرام اسمه الكاباسيتي بيلدينج. الكاباسيتي بيلدينج مقسوم جزئين، جزء تكنيكال بيتكلم عن كل العلوم الصيدلانيه، والجزء الاخر جزء سوفت سكيلز. عندنا كمان على الويب سايت بتاعنا عندنا ويندو كده اسك ذا اكسبرت، ممكن كل صيدلي يحب يدخل في اي توبيك او اي حاجه ساينتفك هيلاقي الرد من حد اكاديميك متخصص. بلس طبعا السوفت سكيلز بروجرامز اللي احنا عاملينها ان كوبريشن مع الديفرنت. نيكست بليز. طبعا من ضمن التولز اللي احنا we are relying on to achieve الجولز والاوبجكتيفز بتاعتنا الارب انترناشونال فارماسي كونفرنس، وده الانيوال انترناشونال كونفرنس اللي احنا بنعمله كل سنه، وده بدا في سنه 2017 اللي هو اسمه ايبك AIPC Arab International Pharmacy Conference. هو بيتعمل كل سنه في شهر مارس. الحقيقه السنه دي كان فيرجن نمبر 4 كان 8 و9 مارس، والحقيقه اول ما المؤتمر خلص على طول اتمنعت المؤتمرات في مصر نتيجه للكوفيد 19. We hope ان شاء الله ان احنا we could host and organize 2021 وتشرفونا ان شاء الله في القاهره. وهو بيبقى طبعا CPD Continued Professional Development Certified من اليو كي. ايضا احنا we cooperate مع national international scientific entities و leading pharmaceutical corporations علشان برضو زي ما قلنا to create و disseminate knowledge و best practices. وطبعا احنا بنحاول في كل الاكتيفيتيز بتاعتنا اللي احنا بنعملها ان احنا نكون accredited من well organized partner ويكون معانا CME او CP. Next. طيب هنشوف بقى الجزء التكنيكال. احنا بنتعاون مع مين وبنحاول نقدم ايه علشان برضو نبقى بنغطي الجزء اللي فيه براكتس لكل الهيلث كير بروفيشنالز مش بس الصيادله. نيكست. نيكست. طيب احنا عاملين بعض كوبريشن بروتوكولز وميموراندوم اوف اندرستاندينج مع بعض الاورجنايزيشنز. احنا هنتكلم النهارده عن الفيزيشن ميديكال اند سيرجيكال سكيلز اديوكيشن اللي بنقدمها فايا انسيجن اكاديمي. انسيجن اكاديمي دي فروم يوروب وبيست ان امستردام. هي بتتكلم عن preparing the operation room with step by step access اكثر من 300 procedure from all disciplines. بتتقدم على هيئه 3D from the surgeon point of view واكريديتد من الرويال كوليدج اوف سيرجنز في اليو كي. احنا مضينا معاهم بروتوكول تعاون واحنا نقدر ان احنا نتعاون معاهم في اي حاجه كنتوا عايزينها سواء كانت اونلاين او ممكن ان احنا نرتب لو عايزين تشوفوا حاجه ديمو لايف. فدي كانت اول اتشيفمنت احنا عملناها ان احنا تعاقدنا مع انسيجن واحنا برضو عملنا معاهم تجربه هنا في القاهره من خلال القصر العيني وكانت ناجحه جدا. وكان في كلام قبل كوفيد 19 ان احنا برضو هنعمل بعض الاكتيفيتيز في الكويت لكن طبعا الامور اتعطلت. وان شاء الله برضو هنحاول بالتنسيق مع السعودي كارديو كلينيكال فارماسي من خلال الدكتوره فخر ان احنا نرتب بعض الاكتيفيتي معاهم ان شاء الله. نيكست. الفارماسيست ريكوايرمنتس زي الهيلث كير سوليوشنز اند مانجمنت ماركت اكسس نيجوشيشن سكيلز تندر بزنس مانجمنت. احنا بنغطي كل الاكتيفيتيز والسكيلز المطلوبه دي من خلال الكولابوريشن مع ال HTA اوفيس اللي هو هيلث تكنولوجي اسسمنت ودي بيز ان كايرو. وال HTA فيلوشيب بروجرام سيرتيفايد من الايسبور اللي هو ايجيبت تشابتر اند ويفور انستيتيوت ان جيرماني. ودي برضو ان شاء الله اللي هي الرئيسه بتاعتها الدكتوره جيهان السيسي. شي از ويلنج ان هي تدي اي تريننج بروجرام سواء اونلاين من خلال ويبينار ومن خلال الجمعيه طبعا فاي حد ليه اي نيد في البوينتس اللي قلناها دي مشكورا ممكن يراسلنا او يراسل الدكتوره فخر، واحنا جاهزين ان شاء الله ان احنا to provide you with all your needs. Next. برضه لو جينا نتكلم عن السوفت سكيلز، احنا عندنا تو اكاديميز يعني فيري بروفيشنال. واحده في بيزد ان لندن اسمها امتا انترناشونال ميديكال تريننج اكاديمي، وده رئيسها الدكتور عارف، هو الدنتست. وعندنا كمان اكسترا مايل وبيز في كايرو كونسلتنج اند تالنت ديفلوبمنت، ورئيسها الدكتور نادر الشاطر. الحقيقه الاثنين فيري بروفيشنال، اي نوع من انواع السوفت سكيلز اللي محتاجينه وي كان بروفايد. وحاليا احنا بنجهز تريننج بروجرام فور كرايسيس مانجمنت. واخيرا طبعا الكوبريشن المميز جدا ما بيننا وما بين جمعيه القلب السعوديه من خلال السعودي كاردياك كلينيكال فارماسيست. احنا ان شاء الله عندنا مجموعه من الاكتيفيتيز مش هنعلن عنها دلوقتي، انا هسيب الموضوع ده للدكتوره فخر اللي هي تعلن عنه ان شاء الله. وكنا من فتره قريبه جدا يعني بنتناقش على مجموعه الاكتيفيتيز وازاي تكون كاستمايزد اكوردنج للنيدز بتاعت الكلينيكال فارماسيست، وان شاء الله هتسمعوا اخبار حلوه قريب ان شاء الله. نيكست. طيب انا قلت كده مجموعه من الاكتيفيتيز، لكن مش كل الاكتيفيتيز اللي بتعملها، لكن احب برضو في الاخر ان انا اؤكد على ان احنا معانا كرو قوي جدا من الناس الاكاديميك والناس اللي هم شغالين في الهوسبيتال فارماسي، عندهم great experience. all are willing to support you whoever you need and whatever you need. Please just submit your request and we can support you with whoever you want. الجمعيه طبعا جاهزه ان هي تجيب لكم كل السبيكرز من الوطن العربي. احنا حتى جبنا السنه دي سبيكر من امريكا ومن انجلترا ومن كازاخستان في المؤتمر بتاعنا ومن استراليا، فما عندناش اي مشكله خالص ان احنا تكفر النيدز بتاعتكم. وان شاء الله ما يكونش في عندنا اي عائق مادي، لان احنا بنعمل الكلام ده ان كولابوريشن مع الفارماسيوتيكال كوربريتس اللي هي ويلنج برضه ان هي تسبورت الصيادله والميديكال كوميونتي ان شاء الله. لو اي حد طبعا عنده اي استفسار او يحب ان هو تو جوين الاسوسيشن بتاعتنا، انا منزل على الشاشه. نيكست بليز. هنشوف هنا برضو على السلايدز دي الويب سايت بتاعنا، تويتر، لينكدين، الفيسبوك، والرقم ده رقمي انا الشخصي لو حد عايز يبعت لي اي واتساب او يستفسر عن اي حاجه انا تحت امركم في اي شيء. واحب اقول لكم ثانك يو. شوف دكتوره فخر لو كنت تحبي تساليني عن حاجه او انا ناسي حاجه اقولها. دكتوره فخر.
ايوه الله يعطيك العافيه دكتور. لا ما شاء الله عليك، يعني كفيت ووفيت، ممتاز. introduction to your group it is so clear. برضو كنا بس نبغى نعرف how do you run the pharmacovigilance في Egypt، خاصة إنه في بعض الآن الاناونسمنت على بعض الميديكيشنز. if you can give us like information about that. الدكتور ناصر بعد كده هيتكلم عن الاكسبيرينس السعودي اكسبيرينس.
طبعا هو صعب جدا ان انا اتكلم عن الفارماكوفيجيلنت ولسه الدكتور نصر هيتكلم عليها، فانت بتحطيني طبعا في تاسك في منتهى الصعوبه. لكن انا هتكلم على تجربه يعني حصلت في مصر. احنا كان طبعا حصل وورلد وايد اناونسمنت على بعض الامبيورتيز اللي موجوده في الزنتات، وكان اعلن عنها شركه DEA. واحنا بسرعه هنا تفاعلنا مع الموضوع من خلال الفارماكوفيجيلنت ديبارتمنت، وكانوا هم اعلنوا ان ماده الرانيتيدين اكتشفوا فيها بعض الامبيورتيز اللي هي ممكن تسبب الكانسر. والماده دي اسمها NDMA نيتروزوميثايل الانين، نيتروزو دايميثايل الانين. والماده دي كامبيورتي بتسبب الكانسر وخصوصا على اللونج تيرم يوز. فتم سحب كل البرودكتس الموجوده في الماركت اللي فيها رانيتيدين، كانوا 21 مولكيول. احنا ابتدينا كجمعيه ننتبه لاهميه الفارماكوفيجيلنس كنوع من انواع جيت للكوميونتي عموما، وابتدينا نتواصل مع الاداره المركزيه لشؤون الصيدله اللي هي حاليا الاي دي اي، الهيئه العليا للدواء. وكان عندنا انيشيتيف كجمعيه وبدانا في تطبيقه، تعطل بس شويه عشان الكوفيد 19، لكن ان شاء الله قريب هنكمله. ان احنا طبعا عرضنا عليهم الشغل بتاع الفارماكوفيجيلنس يكون كله ديجيتالايز، وان احنا هنعمل موبايل ابلكيشن. الموبايل ابلكيشن ده هيكون مع كل الصيادله في الكوميونتي فارماسي، بحيث ان هو يسهل عليهم عمليه الريبورتنج. وهنعمل بوسترز، البوسترز دي هتتعلق في الصيدليات، بحيث ان كل يعني مش كل مريض يدخل الصيدليه علشان يصرف دواء يقدر يقرا يعني ايه فارماكوفيجيلنس، ان هو تو ريبورت اي سايد افكت او اي سيفتي ايشو للصيدلي بتاعه، والصيدلي بسرعه هياخد الكلام ده وهيسبميت النولج دي كلها من خلال فورم موجود على الابلكيشن. فالداتا كلها هتتجمع في وقت واحد في السنتر بتاع الفارماكوفيجيلنس. واحنا كجمعيه برضه عاملين مع بعض اورجانيزيشنز عاملين انسنتيف سكيم، بحيث ان الصيدلي اللي هيقدر يعمل اعلى ريبورتنج او كوميونيكيشن هيبقى ليه ان شاء الله انسنتيف محترم. فهوبنج ان شاء الله قريب نقدر ان احنا نطبق البروبوزال ده ويكون ليه نتائج كويسه ان شاء الله على الكل.
Inshallah. Thank you very much, Dr. Samer. My audience are actually complaining, why are we speaking in Arabic? So they want us to speak in English, which is for us, it's okay. Inshallah, we'll continue the webinar in English if we can. Thank you so much, Dr. Samer. Now it's time to introduce Dr. Nasser. Dr. Nasser Al-Gahtani, he's a very dear colleague to me because we share the same interest. Dr. Nasser, he is the Executive Director, Drug Affiliation in Riyadh, the first center of health cluster in the Ministry of Health. He's so active. I remember when he started the pharmacovigilance a few years back in the Saudi FDA, he was passionate about it. And really, honestly, the time he was talking about it, I felt how important as a pharmacist we are for the pharmacovigilance. That's why I said, no, we need to share his knowledge altogether. It's very pleasure for me, Dr. Nasser, to introduce you. And please tell the audience how simple pharmacovigilance is, especially when the speaker is talking about it in passionate and in good experience. So the panel is yours now.
Thank you so much, Dr. Fakhr, for introducing me. And I would like to thank you for giving us this opportunity actually to talk about a very vital topic, which is a pharmacovigilance and how to use different pharmacovigilance methodologies to induce more safer and rational use of medications. So I'll discuss in this slides the role of pharmacovigilance activities in some Saudi hospitals, and I will show you some real-time experiences from different institutions. So in this presentation, I will talk about the basics of pharmacovigilance and the importance of drug safety communications and how to boost the drug safety culture in different institutions, and the importance of partnership between regulators and healthcare institutions to push up the drug safety culture. Same thing, I will discuss it with the impact of reporting culture and the impact on the practice as well. And last but not least, I will talk about the real-time examples of the regulatory decisions and how these examples or these decisions support the drug safety culture in different hospitals. Let's start with a very simple definition of pharmacovigilance. Pharmacovigilance can be defined as, or simply as, pharmaco and vigilance. So we have actually two terms. The pharmaco, which is the medicines or cure. Vigilance is actually to speculate or to watch or to monitor the effects of the medications. This will take us to more professional definition of pharmacovigilance, which is the WHO definition. This is actually a very widely accepted definition. They define the pharmacovigilance as the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problems. Pharmacovigilance is a dynamic process, actually, and it's a system for monitoring the safety of all marketed products. We are basically focusing on the post-marketing phase. We are not taking care of the clinical research phases, which is phase 1, phase 2, phase 3 clinical research. The pharmacovigilance is called even the phase 4 clinical trial, because we are collecting the data on longitudinal basis. This system actually has many dimensions. The first one is to help actually in early detection of the safety issues by collecting data from spontaneous reports, from literature, from other regulatory agencies, and even from marketing authorization holder and drug industry. All of these data sources will be actually collected and put in one database. If we collect the data, after that, we can actually generate the signals. The safety signals can be generated, then we can detect if there is really a significant signal. After that, we assess this signal through a specialty group or through a national pharmacovigilance committee. After we came up with a decision or a regulatory decision, we will communicate this safety information to the concerned people, whether they are healthcare providers or public members. And some medications actually have some sort of FREMS or risk minimization measures need to be actually followed by clinicians to make sure that the medications actually are administered in a safe and rational manner. As I said, safety communication is very important and has enormous role to have actually a precautionary measures for the medications used. These safety communications can be circulars or memos or dear healthcare professional letters, risk evaluation mitigation strategies, or risk minimization measures. According to the WHO, the risk can be defined as the probability of harm being caused or the probability of occurrence of the harm itself. It's actually the safe, we are talking about the safety communication, one of the composing elements and the integral part in designing a risk analysis, risk assessment, and risk management plans. The aim of these communications actually is to offer essential information in order to decide a proper way to cope with the risk obtained by certain medications. The risk of or the risk communication concerning a pharmaceutical product always should be balanced according to benefit risk basis. As I said, partnership with different agencies is really very important to boost the spontaneous reporting system. Saudi FDA has an initiative actually to collaborate with different entities. I mean the healthcare providers such as National Guard, Armed Forces hospitals, Kingfisher Specialist Hospital, university hospitals, as well as the Ministry of Health. The benefits of such a partnership is to strengthen the practice capabilities, to show the clinicians the importance of medication safety, creates a potential for more innovative methodologies and way of communication between the regulators and practitioners. It's very ultimate goal of the spontaneous reporting system and pharmacovigilance in the country is to enhance public health protection by ensuring safe use of medications, improves efficiency and harmony and better communication between different entities, I mean the health entities within the country. So all of them will be on the same page. and they can actually work on the medication safety issues very efficiently, improves access to safer medication or medicinal products, and enhances the collaboration and information sharing. And this is really very important. Actually, we lack a lot of common databases that will help us actually um, have more representative data that will help us generate signals. The aim of this partnership actually is to bridge the gap between the regulators and practitioners, as I mentioned before, to help monitor the safety of medicines on the national level, not only on the institutional level, support taking appropriate decisions either locally within the institution itself or the group of institutions, and on a national level. When it comes to taking a decision on a national level, that made it's very, let's say, generalizable and can be extrapolated to the whole national population. Building up a database to generate safety signals on a longitudinal basis. The impact on reporting rate. I took an examples from 5 MOH hospitals after they signed MOU with the Saudi FDA to establish a new pharmacovigilance office in their hospitals. You can see that they actually signed a memo on March 2019, and you can see the exponential increase of reporting rate since they signed the memo. And you can see some of the reporting rate has been increased by 1,000%. For example, the King Saud Medical City and King Salman hospitals, both are institutions within Riyadh and belong to MOH. They used actually to report average number of reporting is 20 or less than 20. Now they are reporting average number of medication incidents of almost 500 plus. So this is really very important, and it shows the importance of establish some collaboration with different entities in order to enhance the level of medication safety. The impact on practice is really very influential. It creates a potential for safer practice by default, disseminates the concept of just culture, and nobody will be blamed by reporting a medication incident. Adaptation of reporting culture as a professional obligation. All the healthcare providers need to digest reporting of medication incidents is part of their professional responsibilities, and they will take care of these things. Practitioners realizes the impact of reporting to overcome some unwanted medication outcomes, improves the communication among healthcare providers. I mean, between the physicians, between the pharmacists, and other healthcare peers. Here are some examples of the Saudi FDA circulars and memos that has been disseminated during the last couple of years, and it has really a very huge impact on the practice. For example, we have here one of the circulars talking about the fentanyl patches and how these patches actually used with some pediatric patients. They are highlighting some of the medication errors in here based on the medication incidents reported to the Saudi FDA. Same thing for the pethidine use, and they have another circular addressing the risk of serious hypersensitivity reaction with the intravenous iron products. This is another example. The Saudi FDA receives many reports addressing that the paracetamol causes a toxicity for some infants and some pediatric patients. And after they collect all of these data, they came up with a safety signal. And after they analyze all the reports, they came up with this decision and this communication. This is a kind of safety communication that has been disseminated to different healthcare providers in order to overcome such an error. As Dr. Samer mentioned, the NDMA tragedy has been very influential in the last 2 or 3 years. We started with the valsartan. Valsartan is one of the antihypertensive medications. And this is the first incident or the first circular has been disseminated and circulated by the different regulatory agencies, not only by the Saudi FDA. And it actually helped different institutions to voluntarily recall these kind of affected medications from their institutions. And they advise on how to use other safe alternatives. The second thing, which is ranitidine, all the products containing ranitidine should be withdrawn from the market. And this is what has been actually done by the Saudi FDA here, and it has a huge impact on the practice. Until the moment, we don't have actually a better or on the same class alternative, and but we are actually planning to shift patients on other PPIs or other similar medications. The other thing, which is recently published by the regulatory agency here in Saudi, which is metformin, and it's actually and it has been actually affected with the NDMA, as we mentioned. Actually, NDMA is becoming more problematic nowadays, and different regulators actually they are start analyzing all the medications, making sure that we don't have extra amount of particulate matters, and one of them is NDMA. That's it, and thank you so much.
Thank you very much, Dr. Nasser. It was a very informative presentation, and prepare yourself for the questions. It's coming in the end of this webinar. It's a pleasure now to introduce Dr. Hind Al-Midamir. Dr. Hind Al-Midamir, she is a cardiologist, clinical pharmacist in the National Guard Hospital. She's also academic, teaching our junior pharmacists to become, inshallah, a great pharmacist in the future. By the way, she's my friend, she's my colleague, but again, professionalism is important. So please be with us to talk about the polypharmacy and how this problem is really a chronic problem, especially in patients who are suffering from a chronic disease, cardiology or metabolic syndrome in general. Dr. Hind, please, the podium is yours. Go ahead.
Thank you, Dr. Fakhr. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to actually, this presentation is just an introduction for the things that, why do you think it's important for us to address the polypharmacy, especially in chronic diseases, diabetes and cardiovascular disease. So as of conflict of interest, I have nothing to declare pertaining to this presentation. Now, beginning with this quote from Sir William Osler, to desire to take a medicine perhaps is the greatest feature which distinguishes man from animals. Because animals, they don't like to take medicine. We do, we love that, we enjoy it. At the end of this 15-minute presentation, I hope that you can grasp the concept of polypharmacy, its impact and the patient's outcome, and what's the role of the pharmacist in managing polypharmacy in patients with chronic diseases, especially cardiovascular and diabetes. And then, of course, we'll go over a process called the deprescribing, which is now is the trend with the new to manage polypharmacy. In essence, why do we care? Because we got an aging population, and as Dr. Fakhar mentioned earlier when she introduced the clinical cardiology clinical pharmacist association, she said probably because we do have an aging population that requires medicine, requires clinical pharmacist intervention, and then polypharmacy is actually the norm now, so we cannot avoid polypharmacy. By definition, historically, we used to define polypharmacy as the use of 5 or more medications every day. But truthfully, in the recent years, there has been a switch in the definition, where now we define them as, it doesn't matter how many medications you have, or actually the patient is taking or being prescribed by a physician or someone, as long as it's clinically appropriate. So anything that is not, clinically appropriate, that exceeds the needs of the patient, is considered inappropriate polypharmacy. But also remember that when we put in this definition as the polypharmacy, when we talk about the 5 drugs, we're only talking about prescription drugs. So that does not take into account any medication, any over-the-counter, herbal products. All these are not even included. So you can think about this, especially nowadays with this multivitamins and the era of multivitamins and all of this herbal products, that should be also considered, but it's not in the definition. So why do we care about when we mention the cardiovascular and diabetes in particular? For one reason. If you see here, and this is actually this study that I was part of this study actually with Dr. Ben Saleh, Professor Ben Saleh. If you see here, the percentage of the polypharmacy in patients with dyslipidemia is like 90%. Patients with hypertension is actually 81%. Patients with diabetes is 70%. So that's the percentage of the polypharmacy. That's where the focus was in cardiac and diabetic clinic. And if you see here in patients with cardiovascular disease, if you see here the number of patient here, the polypharmacy, normally they will be on a 5+ drugs, and those cardiac medications are almost 4 medications per patient. That's a lot for a patient. When it comes to diabetes, if you see here, if you compare the green is diabetic patients and the controls, like any other patients, they're the blue. In all medications across the board here, you will see diabetic patients, they're more likely to have that drug, which means they're most likely to be on multiple drugs. So why do we need polypharmacy? Because as we said earlier, there's an appropriate and inappropriate polypharmacy. The main reason is that basically it's prescribing according to the guidelines. And if you see many guidelines now, they recommend multiple agents. Let's take, for example, the hypertension guidelines. If you're treating hypertension, historically we used to say maximize the dose to the maximum tolerable dose, and then before you switch to something else. But the recent guidelines said, no, you don't have to expose the patient to the side effects. You can start with, just give them most effective dose of each drug category, okay? Another reason, and this really common in our region, multiple prescribers, because the patient can be seen, in, for example, the National Guard, and then the next month will be seen by, at King Khalid, and in 3 months he will be seen in, a military hospital. So that's basically multiple prescribers, they're not linked to each other. Everyone will be adding something to the patient. Of course, the aging population, the complex drug therapies of a psychosocial, and of course, the adverse drug reaction. And the problem is, people or prescribers, instead, once the patient develops side effects or an adverse drug reaction from a drug, they think this is a new clinical disease, or this is new disease. They don't go back and track where did that happen, and is it adverse event from a drug that could be avoided by switching to something that does not cause that reaction. Okay. For example, sometimes if you give a patient, okay, let's say a painkiller, for example, and the patient developed constipation, and this patient can be on a painkiller that does not cause constipation. Some prescribers will just go ahead and prescribe doxystate or stool softener, or something for the constipation, instead of like stopping the drug and switching to something that is safer. If you see here, for the polypharmacy, we have appropriate, and that should always be guideline based and evidence based. And then this is a clinical situation where you have to balance between the appropriate before it turns into inappropriate polypharmacy. Okay, and that let me just put misprescribing, underprescribing, and overprescribing a really, really big problem. And I'll show you example here. And I'll show you an example here. I cannot move. Okay, let me just. For an example for the underprescribing, okay, you see here, this is metformin. And the problem, if you see here, the most effective dose should be around this range. But you see, majority of the countries, they don't rarely reach the 2,250 as needed. And the reason for this is because of the side effects, okay, for the GI side effects. And if you notice here, that once you increase the dose, the side effects, the GI side effects will increase, which will lead to stopping the metformin. And again, we're talking about metformin that is the normal the immediate release metformin. One of the ideas is to use the XR metformin, and the incidence of the GI side effects were actually way less with XR compared to them. Compared to the single or immediate release metformin. So that could be fixed. Your problem here can be fixed by switching to something that is longer acting. Overprescribing example, and we see this all the time, either in the cardiac or in the diabetic clinic, where aspirin use in primary prevention. And also another example is the GI prophylaxis. Okay. If you see here, and that will show you, illustrate to you. If you see here, here's a bit appropriate, the proportion of people using inappropriate or unneeded or unneeded or not indicated aspirin compared to the age group. And you see, the more, here, this age group, they actually record the highest, of inappropriate or unindicated aspirin. For the PPIs, there's this one study who showed clearly 90% of patients, they actually did not need PPI protection. But you see, once the patient get admitted, all patients, they were started on prophylaxis, and then they will be discharged on the PPI. And they come to the clinic, the cardiac clinic with the PPI, and there's no indication for that use. So there is something that you really have to keep an eye on. For example, not every patient, there's a criteria to use PPI. And it's even the same thing for aspirin, because some people will just give heart failure patients aspirin, and that's not really the case. It should not. That's not one of the indications for aspirin. What would happen if you continue inappropriate polypharmacy? Duplication of therapy, and then that would cost a lot of money, of course. Definitely decrease adherence, because the more medication patients have, then basically they most unlikely they will be adherent to their therapy, and they will decrease quality of life, and of course increase the emergency department visits. What should you do as a pharmacist? Well, we do a lot of things. If you see, we do intervene, and this is overall picture what do we do in the cardiac clinic, but this is in general. It's not necessarily to be only for the polypharmacy. We do it in general, like patient education. We manage medication. We assess cardiovascular risk factors, and we collaborate with other, healthcare workers, physicians, nurses, to actually minimize, to optimize the therapy and minimize side effects. And of course, that will end up saving your cost. How should you manage polypharmacy? And this is just a general approach. Assess the patient, you define your goals, you identify medications where they have potential risks, and then assess risk and benefit, and the patient actually needs it. And then you move on to actually monitor and adjust your medication. What do we do as an intervention? As pharmacists, we do actually play a key role in evaluating patient medication regimen for appropriateness based on the clinical indications and patient-specific factors. Because every individual, every therapeutic plan should be individualized for the patient. So what a pharmacist should do, to just review the patient drug therapy. You assess the patient adherence, you ask what the problem with the side effects, and you ask them to show you their medication list, to compare it, the list the patient has, with the physician's patient medication list. And then you do have to ask to bring all the medications container, because that will be your way of assessing adherence as well. And then the medication list should include also nutritional supplements, vitamins, over-the-counter herbal products, all of them, okay, because of the interactions, and of course, because you want to assess the number of medications that the patient is using. We also do monitor drugs, okay, and we do provide patient education regarding medications and how to correctly take them. And this is fundamental job of the pharmacist, or function of a pharmacist, okay. It's really, you will see all across the board, we as pharmacists are involved in a lot of clinics, and there's these studies that showed that our involvement in the heart failure showed greatest impact on the reducing readmission rates. Now, what do we mean by de-prescribing? De-prescribing means either medication withdrawal, that means you just stop the medication, or you reduce the dose. These, either doing the withdrawal or reducing the dose, will prevent drug-related problems, will improve the patient quality of life and outcome, and it definitely will reduce the cost. How you do it? You review and reconcile, and reconcile means you just match, the patient medication, assess the risk of adverse drug event, assess candidacy for individual medications, and then prioritize drug discontinuation, discontinue, and monitor, okay? It's important to monitor too, because sometimes, even if you think this is actually an extra medication, sometimes the patient got used to it for a long time. And this is actually a real story that happened. There's a patient who used to be on 9 medication and was de-prescribed to 2 medications. And because they realized, because when they assessed the compliance, apparently the patient was not adherent to her 9 medications. And that's why, after discussion, they reduced the medication for 2. In conclusion, multiple drug therapy has become the standard of care, so we should accept it part of life, unfortunately, especially most of the chronic diseases. However, the drug regimen must be regularly reviewed and evaluated to ensure that unnecessary and redundant medications are discontinued. The pharmacist's main responsibility is to maximize positive outcomes of drug therapy and minimize drug misadventures. Patient therapy should result in the achievement of definite outcomes that improve the patient's quality of life. These are my references, and I'm done. And I believe the questions will be at the end.
Thank you so much, Dr. Hind. Thank you so much for everyone. I think now everybody is interested to start our question session. So can we have Dr. Nasser, Dr. Muhammad, Dr. Samer, and Dr. Hind? We have a lot of questions from our attendees, and I will take them actually, let's say one by one, so we can answer all the questions. For the people who are asking again for the CME hours, for the certification, as I told you, it is a 2-hour CME hours, and it will be inshallah at your Saudi Council number. Inshallah, within as they said, 10 days, and the end of the month, you will have it in the Saudi Council number. الحاجة الثانية, I want to thank Merck for their sponsorship. And also I want to thank my speakers actually, because it's a very nice webinar. You can't imagine the number of attendees. We had the full capacity. I had lots of people who tried to enter, but unfortunately we couldn't for this webinar. But inshallah, we will have a next webinar where we can have them all, inshallah. Dr. Muhammad, because you are our first speaker, I had a question telling us that about the levels of T3 and T4, and also the low level of the TSH. Now, the question I think they want to ask you is, which one should we depend on, the T3, T4, or the TSH? I know, again, we are pharmacists, but we can tell actually which one should we count on for diagnosing the hypothyroidism. So which one should we start with, and which one is supposed to be the indicator for hypothyroidism in this patient? Is it the T4 and T3, or is it the TSH?
Great, thank you, Dr. Fakhr. As it was mentioned in the presentation, we first of all, we scan and we screen for the TSH as the number one. Once we will have an elevated TSH, we will go for the second screening, which we will go for the T4, the free thyroxine or T4 test. And based from that one, we will start the treatment. We will not depend on the TSH elevated. Yes.
Okay, and I think also we had a question. They were telling us which one should we start counting on, the comorbidities or the TSH levels? I think what they mean is that should I have all the patients screened with the TSH, or there should be
no. Once the patient faced the symptoms of hyperthyroidism, then he will be or she will be eligible for screening of the TSH. Not everyone, definitely not everyone.
Yeah.
However, maybe in the female, especially in the elderly, I believe it's one of the recommendations to have them screened for the TSH.
Okay, question for Dr. Nasser. They're telling us where does the pharmacovigilance pharmacist work? That's a good question.
Pharmacovigilance pharmacist?
Yeah, where does they work?
Pharmacovigilance is a shared responsibility, but basically they are working in regulatory agencies. So they are taking care of all regulatory aspects. You know, pharmacovigilance is a purely regulatory science, and it's not actually belong to practice. But you know, we can have some pharmacovigilance pharmacists working in some institutions as a key contact person and connecting the institution with the regulatory agency. But conceptually, pharmacovigilance pharmacist can be either in the regulatory agency or can be part of the marketing authorization holder or the pharma industry.
Okay, so it's not a job that the pharmacist will take it in a special unit isolated from others. It's supposed to be in everywhere, any institution where you assign a pharmacist for the pharmacovigilance.
Yeah, but it's more prevalent with the regulatory agency and marketing authorization holder.
Okay. I have a question. I don't know to give it to whom. Let me see. Can we dissolve the drugs in milk or water for pediatric? Who would like to take this question?
You mean the levothyroxine or any other?
In general, they're asking, yeah, levothyroxine is one of the drugs, but in general, if we have to dissolve a drug, would you recommend milk for the dissolution, or
No.
do you use water?
I recommend, yes, water.
Well, only water, no milk, because
Regular water.
Yes, because water will be safer. Because milk, you don't know what kind of interaction. It could be a chelating agent, you know. It could you don't know. But definitely, water would be safe. Nothing wrong with it, but except for the stability, of course. If they dissolve it, it has to be used immediately. The rest that is not used has to be thrown, or, you know, you get rid of it.
Okay, great.
One thing more that I want to add: adding any medication to a milk will change the taste of the milk for the child. Then the child will eventually reject this because it has a different taste, and this will result eventually in more consequences than having it in a regular water. So water is safer. Water has no taste, so it is better to use the water.
Pharmacovigilance question. You said now we have some reports telling us, like, for example, you gave an example for valsartan, later on also for other molecules like metformin, and it was actually maybe the recent one was metformin. The question they're asking us, what's wrong with you pharmacists? After using the molecule for a long time, we just take a decision that we want to get it out of the market. So what's going on? I think this question is for Dr. Nasser and for Dr. Samer. Why you're giving us a molecule that we use it for ages, like for patients, and then, like, for example, ranitidine and so on, and then you tell us, okay, now it's over, don't use it again. So what's going on? What's happening?
Should I start or Dr. Samer?
Yeah. Okay, Dr. Samer, are you there?
Yes,
Yeah,
I'm
you
there.
want to start? Yeah.
Dr. Nasser, please start.
All right. So sometimes, you know, in the manufacturing process, you cannot control sometimes the raw materials. When a marketing authorization holder or a pharma industry submit a dossier to the regulatory agency trying to get that medication registered, they actually submit full GMP profile, which is the good manufacturing practice profile. And the regulatory agency will have some visits to the manufacturing sites, making sure that all the raw materials used are up to standards and safe to be used in that medication. The reason that the NDMA levels has been increased recently because some of the manufacturers actually change the source of raw materials. And they got actually cheaper raw materials from China, basically. And they try to incorporate these kind of raw materials into the medications. That's why they caused an increasing level of NDMA. NDMA is not a problematic by itself. NDMA sometimes, you know, found on some food stuff, found in some other medications, but with acceptable limits. However, the main actually issue with this, you know, the manufacturing process itself is very dynamic, and we cannot actually control the sequence of supply chain of raw materials. And you know, the regulatory agency have let's say recurrent analysis for all the medication batches, and if they discover some old contents, they will right away publish this to the concerned people, and they actually have the responsibility to communicate these safety information either for public or for healthcare providers.
I have a comment, Dr. Nasser. Let us hear Dr. Samer first.
Okay, you know, we have been using ranitidine for almost more than 30 years. It's a molecule that lost its patency, and we have a lot of generics. And people are wondering why we didn't discover before the NDMA impurities in the ranitidine molecule. I think, like Dr. Nasser has said, number one, due to the variations in the supplies from different agencies who are supplying the active ingredients. They are not all at the same quality of standard medications or raw material. Number two, I think the analytical procedures are depending more on technology, and the technology could nowadays or at the recent years detect minor impurities in any molecules, so that we can find the NDMA and ranitidine not discovered before, and that's why we warned every patient about these impurities and withdrawn from the market.
I think both of you are right, but I have a comment. Always we have to look at the patch number. What I mean, sometimes, like for example, at the last month where we had an announcement about metformin, lots of patients came to the clinic and said, I will not use metformin anymore because it's contaminated, and we had announcement not use it. So I think it's our role as a pharmacist to educate the users that not all the drugs are supposed to be stopped. As you said, it depends on the batch number, it depends on the generic or brand, and it depends on which one we are actually discarding it from the market.
I just want to add one more thing. Sometimes you need actually to voluntarily recall all the batches because all of them actually are contaminated. This is the case happened with the ranitidine as well as with the valsartan because this is actually a universal recall, and all regulatory agencies need to do the same. One more thing regarding why we discover these side effects or these quality issues after a while. These medications got the or granted the approval from the regulatory agencies. This is the beauty of the pharmacovigilance system. It's actually a longitudinal monitoring of the medications. You know, one of the limitations of the clinical trial is the time constraints. We cannot actually detect very long-term side effects of the medications on the clinical research periods. However, after the medication is introduced into the market, they will leave this function for the spontaneous reporting system to discover it. So this is the beauty of the pharmacovigilance, is to discover the long-term effect of the medications.
Right. Yeah, great. Dr. Hind, you have a very important question. And they said there's no hotline for a polypharmacy consultation. The other question is that about the tablets that has a combination of two medications in one capsule or one tablet. What do you think about their efficacy?
So let's start with the hotline. The hotline, I wish, really, but it depends. I mean, sometimes you could call the Drug Information Center. Majority of the hospitals, they accept it, but the thing is, it's only like, you know, from during weekdays, not the weekend. So we lack the manpower actually to do that and to reach that stage. As for the combination, excellent for compliance. We reduce the burden of tablets because again, sometimes if you reduce the number of tablets, you improve compliance. However, our take is sometimes you need to adjust the drug, the dose of one of the drugs. So if it's a combination, then you just wasted all of your, you know, the combination because you have to, because it comes in fixed combination. You cannot modify it. For you to modify it, either you have to actually get some other drugs, or extra dose. So it's good in a way, but not good if your blood pressure or your thyroid, whatever, or even dyslipidemia is not controlled. So it has its own, you know, pro and cons. So it could be, it has nothing to do with the efficacy. Combination is only for to improve compliance because the efficacy, it came from the parent drugs. There's no doubt about it, but it's just you know, again, if you think the disease is not controlled and you have to use extra dose or you lower the dose of one of the combination drug, so that's when you have a problem with it. That's why it's not really likely to be used a lot.
Right. Dr. Muhammad, we left you for some time because you have few number of questions. First of all,
yeah, Dr. Fakhr, there is a question about does the pharmacist have the privilege to prescribe or de-prescribe?
If you want to have it now, or you want to
later? Okay, that's fine. Okay, sure. Yeah.
Because I saw Dr. Muhammad is like losing our attention now, so we just want to catch him.
All right, sure. Yes.
Dr. Muhammad, I have a question. They're asking you, first of all, about the TSH levels. What is the target TSH level? The other thing, what is the maximum dose of thyroxine per day? The other one is, why do we sometimes give doses in the weekdays different than the weekends? Finally, how do you manage a pediatric who have a hypothyroidism?
واحدة تراني ما بكتب، واحدة. خلينا طيب ايش؟ طب أنا I have a comment طيب على الهوت لاين. خلينا just only to share it.
Go ahead.
الهوتلاين يمكن في عندنا في سعودي أرابيا we have the 937. It's a hotline that you can reach pharmacists and you can reach physicians. You can ask them 24/7 any kind of questions regarding your medications, and they will answer you. And if they do not have the answer, they will escalate it up according to the question itself. Very soon, inshallah, we will launch our virtual medication counseling clinics. Maybe it is launched in certain hospitals, but it will be launched countrywide very soon. And this will have a pharmacist that they will be available, and you have to take an appointment with this clinic, and the pharmacist will contact you and they will counsel you virtually to answer any questions from your side. And it will be open to everybody in the kingdom, not limited to any patient or any hospital, private or general hospital. Now we can go to your questions, please. But
Okay.
one by one.
We'll take it because I can see most of the questions coming to you. First of all, they're telling you why you are saying 2 weeks for increasing the dose of thyroxine, while it takes about 4 to 6 weeks to give its effect.
We are not waiting for, this is in the elderly you are talking, right?
Yeah.
In the geriatric patients.
Exactly.
Elderly. We are trying to taper it up, not to balance according to the levels. We are trying it to give the dose, the required dose, which is 1.6 mics per kg per day. But we are not giving it all in once. We are tapering it one by one. So we are giving it, we are starting by 25. Then after 1 or 2 weeks, we are giving it another 25 until we will reach the desired dose. Then we will wait until the effects will start, and then we have to measure. After the 4 weeks, we have to measure the TSH level, and then we can tailor our dose accordingly.
What is the maximum dose of thyroxine per day?
It's a normal hormone. I saw patients, they are taking a lot of very high doses of thyroxine, levothyroxine. The maximum dose that I saw, maybe it reached to 400, 500 mics per day, not per kg, per day. However, it should be balanced with the side effects. Any side effects will start, especially the cardiovascular side effects. You have to reassess all of your clinical pathway that you are following. Then you have to tailor the dose again.
Another question telling us, if you have a child with hypothyroidism and you want to prepare the child for cardiac surgery, what's your recommendation?
هذه لا يفتى وملك في المدينة. يعني دكتورة هند, I believe this question is directly for you.
Okay, so Dr. Hind,
I missed it, sorry.
They're telling us, if I have a child with hypothyroidism and I want to prepare the child for a cardiac surgery,
Okay.
how do we prepare them? What's your
Well,
recommendation?
I'm not sure about children, but I'm not really sure. I'm an adult cardiology clinical pharmacist. I don't do actually children. And
do you have adults who are on thyroxine and then they are assigned for cardiac surgery?
Yes, we do, but we never had a problem. We never had an issue, really. We just prepare them just like anyone else. But the problem is sometimes it's post-op because of, we get, because of the tachycardia and things, but that's the only concern. However, we do not take any special precaution. As a matter of fact, you, Dr. Fakhar, can tell us about your thing, you're a cardiological pharmacist as well. But from our side, we really, we don't have something special. We get scared starting a thyroxine post-op, but that will be only for a couple of days, and then if the patient has hypothyroidism, we start treating. But it's just but pre, I don't I don't recall that we do have special precautions or something that needs to be.
It's like when you're preparing the patients with any other medications, like the ACE inhibitors, the ARB. So what we do
you don't
is
stop.
NPO, you stop it before the operation, and then you can reschedule it again like 1 or 2 days after. Because what we're concerned about is what Dr. Muhammad said, the tachycardia, the effect of thyroxine on the heart. If the patient is already on it, so it's not a concern. But if he's a naive patient, this is where we are actually taking care of.
Correct, yes. That's exactly what we do.
Dr. Hind, your question was for the prescription. So can you tell us your experience about that?
Yeah, well, as a matter of fact, yes and no, as an answer for the question. Are we authorized? It depends on the privilege that is given to the pharmacists by the hospital, because there's a credentialing committee. You have to be authorized to prescribe. And yes, pharmacists do actually prescribe and de-prescribe depending on their privileges. Like, for example, what's happening now in the anticoagulation clinic, and then refill clinic, and a lot of clinics that are run and led by clinical pharmacists. We have full authority to do, to manage our patients. If you are authorized to prescribe warfarin, yes, you can prescribe and de-prescribe warfarin. But then, the same thing, it's a medication management clinic. They will do the same thing. The refill, where they can see all patients and they are authorized to do, but it depends on the privilege that is given to them by the hospital. They cannot just do it. Not any pharmacist can go and prescribe or de-prescribe. It's not. And sometimes when it comes to de-prescribing in particular, we like to take the MRP's opinion before we proceed. Because at the end of the day, it's an interdisciplinary team decision, and it's good to involve the MRP, the most responsible physician, the justification and rationale why you're taking off this medication. But we do have privilege, yes.
I do agree with you. The point here is not actually prescribing by itself, because I know that we work as a team with the physician and the nursing. It's not a kind of, I want to take the authority from the physician. As far as I just want to help in refilling some medications, or if I have like a few comments that I can do an action, like as you said, warfarin, for example, or even the heart failure clinics sometimes, or the diabetic or the asthma clinic, where you have a patient who is a chronic user of this medication, and you can see like some side effects coming up, and then you can stop this medication or decrease the dose, or even start another drug from the same group with less side effects. So I think this is where actually the pharmacist really can work very in a collaboration with the team. It's not like individual.
The whole, as a matter of fact, the whole goal of having these clinics, that are led by the pharmacist, is to optimize the therapy for the patient. So when you want to, as you mentioned, Dr. Bahar, when you want to prescribe or de-prescribe, is to optimize the treatment plan for this patient, not just because you want to brag that I can prescribe. No, it's not. Yes.
A question to Dr. Muhammad, telling you, if you have a patient who is a chronic urinary tract infection, and he's gonna also, or she's gonna be on levothyroxine, what's your recommendations for using antibiotics on the top of levothyroxine?
As we mentioned, levothyroxine it has to be separated from many other medications. Many of medications that they have a contraindication with the levothyroxine. So at least 4 hours separate before or after. I prefer to go with the after one, and we have to measure if he's a chronic patient. The levels of the TSH has to be monitored very closely after that.
Okay, great. Do you have any site where there is a hypothyroidism protocol you recommend for our audience?
I don't have any specific site, but the references in the presentation, those are good for good to be shared.
For our site, So you can have the references there, and also you can follow the protocols in the slides itself. Another question for Dr. Nasser. They're telling you, do you recommend morphine as an analgesics for patients with sickle cell anemia? I don't know why Dr. Nasser is picked up for this question, but you are mentioned by name.
Yeah, I replied to this question through the chat. Yeah, it can be used actually, but they need to apply some precautionary measures.
Like what?
There is some sort of risk minimization measures need to be followed by the clinician in order to give this kind of medications for sickle cell patients.
Okay, great.
It's very detailed, and I cannot actually mention all of them right now.
Okay. Question to Dr. Hind. They are asking you if you have a patient who is a diabetic patient and he's also uncontrolled cholesterol and he's taken statin with 2 tablets of metformin daily. What's your recommendation?
Are you inclined, because I'm not sure about the available combination as well. I'm not sure if we have, metformin that is in combination with the statin. If that exists, that would be great. You can adjust your, so the thing that is not controlled is the lipid, right? Or is it diabetes?
No, it was the lipid.
The lipid is not controlled. But metformin has nothing to do with the lipid, so I'm not sure. Is there a combination? Because I'm not aware of the because I'm not really available for drugs that are available, in the market. Really, I'm not sure if there's a combination drug. We don't have them. We don't carry them in the hospital, and for the reasons I told you before, that we do not prefer combination. For the reason is that it's difficult to adjust the drug. So if it's not, you always have to try. And there's also, I'm not sure, 2 tablets of metformin. With all honesty, I'm not sure what exactly, why is it 2 tablets of metformin? Is it 2 tablets of what? 500, 1 gram?
I think, yeah, he's telling, and he wants to tell us that the patient is on metformin only for diabetes. Okay. So he wants to tell us okay, for diabetes point of view, he's only on the first line of treatment. So what he's concerned about is, I think, the risk factors, which is the atherosclerosis risk factor calculation. Okay.
So did they calculate the 10-year risk? Does he have any other, all of these things has to be considered. They say they have to do the 10-year risk of developing cardiovascular disease. There's no enough information to judge this patient, to judge the status. So a lot of information, background information, history about the patient must be taken before you decide what would be your next plan, okay? And if the patient developed any cardiovascular event before or not. Not necessarily I should jump, and then I don't know if the blood sugar is controlled as well. If it's controlled, then probably, I don't know, even the concentration of the strength of the metformin. Is he, as I mentioned, is he on 1 gram, 2 grams of metformin, like 2 tablets? 2 tablets mean nothing, it has to be, So that's basically, a lot of information has to be done, but you have to optimize. If the patient doesn't have, if the blood sugar or even the blood cholesterol is not controlled, you all have to move a step further. There's a different alternatives, and now even for diabetic drugs, and alternatives also for the lipid lowering agents. So there's a room to improve the patient's cholesterol and diabetes as well. Okay.
So clear. Now we have a question that I want all of our speakers to end up with, which is a very important question. Actually, I think it's the other topic for our next webinar. One of the audience were asking us, what is the soft skills that is needed for a practitioner, of course, pharmacists and healthcare practitioners, from your experience and from your point of view? If you want, we can start by the speaker's arrangement according to the poster itself, or if you want, we can start by just raising hands, and you can just go ahead and answer the question. What do you prefer? In my opinion,
I will just go, if you don't mind.
Okay, so you will start. Go ahead.
Dr. Muhammad, let's just go with the sequence. Dr. Muhammad, تفضل.
Of the poster, yeah. Okay, so Dr. Muhammad, let's start.
Ladies first, دكتورة هند يعني.
لا. You start. ابدا تفضل.
طيب شكرا جزيلا. أنا I believe it's not just only in this topic. I believe communication skills is the key factor for any success. So if you improve your communication skills, you improve your confidence in your knowledge, you improve yourself, and you improve your knowledge about what you know, and you will build the trust between you and the other healthcare team members, and this eventually will result in improving the patient care by working as a one team.
Okay, great, Dr. Samer.
Sorry. Okay, I think this is very important question because it is highly related to the topic of our webinar, excellence in healthcare career pathway. I am sure all skills are very important, but I would like to summarize them regarding the healthcare providers in 7 points. First of all, the effective communication and interpersonal skills. Second, the patient counseling art, crisis management, stress management, emotional intelligence, problem solving, and teamwork. And we could provide all this kind of training programs for all. Thank you.
Okay, Dr. Nasser.
I have nothing more to add صراحة. يعني communication skills really important actually. يعني.
غطى كل حاجة ما شاء الله، عشان كذا كنت أبغى أبدأ أول، عرفتوا عشان أقولها. Yes.
Some
ممكن تأيدي أو you can agree or disagree, but you still have your place to talk about.
Yeah, communication skills. Improve on communication actually with other healthcare peers is very important. Actually, pharmacists need to be trained on client experience actually, and this is really very important in order actually to
أنا عندي إضافة بس كمل دكتور ناصر. دكتورة هند.
build the bridges of trust between the different patients and healthcare providers, as well as with the patients.
Okay.
I totally agree. Yeah, I totally agree with what everyone else mentioned. And again, stressing the communication skills because it solves a lot of problems. We work in a multidisciplinary team that you definitely need to have good communication skills. It's really important. And again, other soft skills, punctuality, commitment, and time management as well. Especially earlier, you find yourself overwhelmed with a lot of things. You have to manage your time wisely. You have to respect others and respect all professions. It's really important. Respect and trust, being a trustworthy healthcare professional, this is really important and it is needed. And definitely, if it's ruined, it cannot be fixed. So, العود على ورق زي يقولون. I'm not sure if they're gonna understand it, but so that's basically what I have to say.
I want to thank you all, of course. My only addition would be احنا ناسين حاجة مهمة اللي هي business part of pharmacy. We're talking about also communication skills for community pharmacy outside. They need an MBA. They need to know about the MBA. The other very important thing, I think, is that also leadership. A lot of us now in positions where there are leaders and they need to know how to work on the leadership also skills, which is للأسف بعضنا just because he's a senior, he is the leader. بس لا، في البعض الآخر بيحتاج مساعدات في leadership لأنه again, leader is different than a manager, and we know the difference between them. كلنا الآن عمرنا في المهنة few years, but we know the difference between a leader and a manager. So I think also this is supposed to be added to the courses that we are doing. I will announce now لأنه جاني سؤال من الأودينس. When is our next webinar? بإذن الله إن شاء الله. كل عام وأنتم بخير جميعا. بعد إجازة العيد هنبدأ نيو ويبينار بإذن الله، هيتكلم برضو عن السوفت سكيلز، عن الفارماكوفيجيلانس إن شاء الله، فارماكو ايكونومكس، and إن شاء الله we have a collaboration مع الام او اتش والدكتور محمد اللي هي السبيشالايزد كلينكس. هتكون معنا طبعا الدكتورة هند إن شاء الله few numbers of experts إن شاء الله cardiologist في البلد. الفكرة كلها إنه we want to expand, we want to إن شاء الله cover everything in pharmacy. On the top of that, we have special courses done through the pharmacy group. It's time to tell you now, we're going to start inshallah في August. وبإذن الله حتكونوا إن شاء الله عن طريق السعودي Heart invited to attend the courses that you want. Thank you very much for being with us. You can't believe that most of the audience still joining us, although we extended the time, which means it was a very good webinar. Thank you so much for our speakers, for your time, for our attendees, for the Saudi Heart Association, and for Merrick for their sponsorship. وإن شاء الله أراكم على خير بإذن الله بعد العيد. Thank you so much. أشوفكم على خير بإذن الله.
شكرا جزيلا.
يعطيك العافية. شكرا جزيلا.
مع السلامة.